Welcome everyone. Welcome to our Capital Health Network's third Practice Connect for this year, for 2024. So Practice Connect is our quarterly networking and educational event for practice managers and practice nurses. Obviously tonight's topic's a little bit more slanted towards the practice nurses. There are seats up the front if it's a little bit hard to hear down the back, if anyone needs to come up, but I will try and raise my voice. I'm Kate Eigner. I'm the manager of the Quality Improvement Team here at Capital Health Network, or CHN, as we call ourselves. And I'd just like to introduce the rest of our QI team that's here tonight. We've got Rachel and Kanal, our events lead, on the tech bench here. We've got Kat down the back. Charlene, you met as you came in, and Taylor is our Indigenous Health Program Officer, who you'll hear from later this evening. So before we get started, I'd like to acknowledge the Ngunnawal people, who are the traditional custodians of the land that we're meeting on tonight, and pay my respects to their elders past, present and emerging. I recognise their ongoing contribution to our region and communities and their connection to land, water and culture. And I also acknowledge and welcome all other First Nations people who are joining us this evening. So some housekeeping, you've probably already found them. The bathrooms are just out in the corridor at the end here if you do a sharp right. If we need to evacuate for any reason, same corridor right to the end, out the green door and outside. What else do we need? And if you haven't grabbed food already, please do. You can just pop over next door. So this evening's format, I'm going to run through a quick update from your primary health network, CHN. Samm Curtis will then run us through optimising and complying with the MBS to enhance patient care, and then followed up by Taylor Carriage, who will talk about MBS items for Aboriginal and Torres Strait Islander patients. We'll leave all questions to the end, if that's okay, just to keep things moving. So, your primary health network update. CHN is one of the 31 primary health networks around Australia, so we're responsible for everything within the ACT. We work within the ACT. We aim to deliver better health outcomes for the ACT community with a focus on vulnerable people and those at risk of poor health outcomes. The way we do this, we coordinate and try and integrate local healthcare services, so working with ACT Health, Canberra Health Services, yourselves out in primary healthcare, to improve quality of care, people's experience and efficient use of resources. We commission, so we do a health needs assessment, which I'll talk about in a minute, to identify any gaps in service delivery, and then commission services to try and fill those gaps, or at least some of them. And we try to build capacity and provide practice support to primary care and mental health care providers within the ACT. So these are our 9 priority areas, which I'll let you read through. And then our health needs assessment, which I talked to before. So this is a very large piece of work. They've asked me to share, because we always value your feedback. We're starting a new platform, an online consultation platform that'll be coming up in the next month. And we'd love to hear from you all, or from primary health care stakeholders, from your colleagues, from your friends. It's not open just yet, but just a heads up that it's coming, and we'll share a link to you all when that's ready. And there'll also be information in our newsletter and on our website about that. Moving on to our family safety team. So this team's fairly new to CHN, and they're working to support the primary care sector response to family domestic sexual violence and child sexual abuse. So at this point, they've commissioned the Domestic Violence Crisis Service and the Canberra Rape Crisis Centre to deliver a 2-year family domestic sexual violence and child sexual abuse pilot in the ACT. So through this pilot, they're aiming to support primary health care professionals to recognise and respond to early signs of FDSV, just as short. Through this is free tailored education and training opportunities for practices. They've also, part of the commissioning is they've commissioned link workers who are embedded with those two services, who will facilitate coordination of referrals from the primary care to appropriate support services, and also enhance service navigation for victim survivors and generally support the practices in that area. So as it says there, we'll be seeking expressions of interest from interested healthcare professionals coming up in the coming months. So keep an eye out for that. If you're interested, you can email the team on familysafety@chnact.org.au or through our primary care inbox if that's the one that you know. Mental health. You may have heard of the Initial Assessment and Referral Decision Support Tool. We call it IAR for short. So this tool is to support clinicians and service providers to make mental health referrals and recommendations. So it's an assessment tool. And the idea is it's assessing across these 8 domains down the bottom here. And through that, it identifies which level of care the patient may require. And the idea being that the service providers are starting to have that information themselves, certainly the mental health services that we're commissioning. So it's a little bit easier for health professionals to then know which services provide the level of care that their patient needs and can make appropriate referrals. So we are offering training on this at the moment to all the professions that are listed there. The QR code will take you to the link to the trainings where you can register. If you haven't got that, you can also just look for IAR on our website for more information. So those trainings are running regularly. Health pathways, which I hope everyone knows all about. If you don't, you've all got a pen or a notepad. So health pathways are our point of care tool. They're evidence-based and locally relevant. As you see there, there's over 660 pathways that have been localised to the ACT. Our Health Pathways program runs in conjunction with Southern New South Wales. Obviously, there's a lot of cross-border there. And there's 3 pathway types: the clinical, resource, and referral. That's what it looks like when you go in. You can search through the sidebar at the side there. You can navigate through to which area you're interested in, or you can search for a topic up the top there, relevant to tonight in MBS items. There's information there on the MBS items for Aboriginal and Torres Strait Islander health, for telehealth and medication management. That's specific to MBS, but there's referral pathways, as you can see, for a whole number of conditions and situations. And how can that help? How can health pathways help you? So it's there to support the clinician. It's also there to help with system integration. So there's advice on assessment and management. There's resources there for the clinician and the patient. Referral pathways, so you can find local services for your patients. And referral criteria, so you can make sure you're collecting all the information that's required for those referrals. If you search for Health Pathways ACT, so you need to leave the ACT in there, otherwise you might end up in another area. And then the username is together, password for health. If you like, there's some stickers down the back. You can take them back to your practice, put them on everyone's computer. So it's easy there, easy to find. And they're always open for feedback. If you know of a service that's not there, if you know that notice something's not right, there's a feedback button on every page, and they're very keen to hear from you. So the quality improvement team, that's our team. So we're here to support primary care with continuous quality improvement, but general practice support as well. We do that through our quick cycles, which is our name for a Plan, Do, Study, Act quality improvement activity, and we can support you with that. Your GPs can self-report CPD hours for their involvement in those. If your nurses are learning a new skill to do that, they can self-report that for their CPD quick reviews. You should have all received, your practices should have all received the quarterly review out last week, covering MBS items. So they're the yellow sheet with all the data points on it. Yep, ringing a bell. Yes, so they come out every quarter, and we try and focus on topics that you can run quality improvement activities on, or reach out to us and we can help you with that. Quick Skills will come out and talk to you about how to analyse and use and analyse and access your practice data that's in the CAT4 program. So you can do that. And a quick visit, we can just come and talk to you about quality improvement and how CHN can help you. And our educational events such as tonight. So if there's anything, any questions, any support, you're not quite sure where to go, anything, please reach out to us through our primary care email address there. So we're talking about MBS items tonight. The general practice in aged care incentive is new. It's part of my Medicare. I'm not going to go into a lot of detail, but I thought it would be appropriate to just do a quick overview tonight. There's a lot of information about this. You may have already seen there's been a few webinars already about this, but we'll just run through it quickly. And if you've got any questions, you can ask later, or we can send you further resources. So officially it started on the 1st of July, even though practices couldn't register from the 1st of August, but the payments will go from the 1st of July. And there it is. The aim is to deliver coordinated quality healthcare for residents of residential aged care homes. So how does it work? Both the practice, the provider and the patient all need to be registered in My Medicare, and that's of course a voluntary thing to do. If they are registered and they're connected up with the GP ACI, which I'll call it because otherwise it's a long mouthful, the GPs and the practices receive incentive payments for visiting and providing that care to their patients in residential aged care homes. So that's $300 per patient per year for the GP and $130 per patient per year for the practice. To be eligible, the practices basically need to be registered in My Medicare and then also registered for the GP ACI program. Providers need to be linked to their practice in the organisation register and declared as what they call the responsible provider of eligible services to their patient. The patient needs to be a permanent resident of a residential aged care home. They need to be registered with My Medicare and linked to the practice and the provider. And then the practice also needs to select the GP ACI indicator on their My Medicare profile. There's no, so residents of aged care facilities are exempt from the 2 face-to-face visits in 2 years that other patients, that requirement for other patients to register with My Medicare. I don't know if I said that very clearly, but there's an exemption there. So to fulfill those requirements, to be eligible, the provider needs to provide 2 eligible care planning services over a 12-month period and 2 regular visits per quarter, each in a separate month, so that there's at least 8 regular services in a 12-month period. It's paid quarterly, so the provider needs to make sure there's enough of those, the correct number of visits in that quarter to be eligible for the payment in that quarter. If a visit is missed in one quarter, you miss payment for that quarter. But if by the end of the 12 months, you've done all the 8 regular services and the 2 care planning visits, then you will get paid for that last quarter. A little bit complicated, just an overview tonight, but we can certainly send more information. And that incentive is on top of course, any of the MBS items that would normally be charged for visiting aged care facilities. So yes, one of the visits needs to be with what they call the responsible provider, the GP, and a second visit within the quarter can be with one of the other providers listed there. Because we're in an MM1 area, there's no telehealth isn't counted under this incentive. Just to share that one. So benefits to GPs and practices, you get payments for reviewing patients in an aged care home rather at their practice. It's just establishing, like with My Medicare, establishing that formal relationship between the practice, the GP, and I guess other members of a patient's care team, because it's trying to encourage that, that team care and increase continuity of care. Lots of resources on the Department of Health's website. There's education on how to register on Services Australia, and we're of course here for any questions to guide you, link you, answer questions. It's all very new. There's a lot of information to take in about that one. So moving along, there's more. So I'll introduce Samm Curtis, who's a dedicated practice manager overseeing 2 GP clinics in Canberra. With several years of experience in healthcare delivery, general practice especially, sparked Samm's passion for providing exceptional patient care in the primary care setting. Somehow she balances her professional responsibilities with motherhood, working alongside her 12-month-old baby in the office each day. And he's even joined her tonight.
He's actually woken up, so
it is both exciting and an honour to be able to model the potential for creating supportive and family-friendly workplaces for women. Samm's hand-on approach, combined with her extensive experience, sees her presenting on a range of topics, focusing on optimising Medicare and DVA billing opportunities whilst ensuring MBS compliance. So thank you, Samm, and welcome.
Thanks for having me, everyone. I'll get started. So tonight I'll be talking a little bit about the upcoming changes to the chronic disease management items. A bit of an overview on health assessments, eligibility and co-billing rules, and the delivery and eligibility of the DVA CBC program, and then just a bit of overall stuff around maintaining compliance and troubleshooting and getting help. So as you've probably all heard, as of the 1st of November, there's some big changes coming to the chronic disease management item numbers. Unfortunately, as is pretty usual with Medicare, we still don't know much about the changes coming. The biggest thing that we don't know is how the rebates will change, if they'll stay the same, and how it will affect us all, and especially in our delivery of chronic disease management to our patients. The things we do know is that items 721, 723, and our review items, the 732s, will cease. There won't be any changes to the patient eligibility. EPC referrals will no longer be needed. So for referring your patients to the multidisciplinary team, it will just be a referral as per what you would do with everybody else rather than an EPC. And just with My Medicare, if a patient is registered to their usual GP through My Medicare, they'll only be able to access the chronic disease management plans with their usual GP. If they're not registered, they can access these item numbers with any GP at any practice. So I think overall, we're all really excited about that. You've probably all had patients that have been on holidays, gone to Sydney or Melbourne or somewhere and need a quick script and go to a bulk billing practice, and suddenly you can't claim their annual health assessment or chronic disease management plan, and the cheeky practice at the bulk billing clinic has taken those items. So with My Medicare, that will no longer be possible, which is a little bit exciting. So these are the item numbers that are coming. So the 721 will now be 965 and the review 967. And apparently there's going to be some telehealth items, although at the moment we can only do video. They haven't actually announced too much around the phone telehealth consult items and what the eligibility will be, but I'm sure we'll all find out soon. So moving on to health assessments. You probably all know a fair bit about what they are and how they're done in the practice, usually with the help of your practice nurses and GPs. There are time-tiered items and also different target groups. Actually putting this presentation over the last couple of weeks reminded me that if one of your patients fits into two of these target groups, they can actually access 2 health assessments in the 12-month calendar year. But you must be very careful about how you notate that to Medicare. They will want to know which target group the patient is in and what health assessment you're billing for. So an example would be if you have someone over 40 to 49, you could do the type 2 diabetes health assessment. And then if they fit into another category, such as having an intellectual disability, you could then do another one within your 12-month calendar year. A bit complicated to keep on top of the notations and what you've done so far. And just with your billing in general, things to consider is with the health assessments, unlike a lot of other MBS items, the time spent with the nurse and the GP contributes to your time-tiered item. So your 45 to 60 minutes or longer, this time spent with your nurse contributes to that total time. A few billing and co-billing rules you may or may not know. So we just touched on this, where if your patient's eligible for 2 different tiered groups, they could have 2 health assessments in the 12-month calendar. There are other scenarios where Medicare would consider the patient to be eligible for another health assessment, and that can be where the patient's moved practice and has a new usual GP, or possibly where their health condition has significantly changed and a new plan is needed. Again, the key to having those item numbers accepted and paid by Medicare is clear notations. And do expect sometimes they still could get rejected. You might need to spend a little bit of time on the phone. So again, just to help Medicare assess the claim, the target groups of the health assessment must be specified, or the reason why you are billing another health assessment earlier than 12 months. So another thing that a lot of practices might not realise is that you can co-claim a health assessment and a chronic disease management item. If you read the descriptors of health assessments and the chronic disease items, you'll notice that Medicare does describe some situations where they would deem it appropriate for you to do so. And those situations would be where it's clinically necessary, or the patient may have significant barriers coming into the practice, such as mobility or overall health condition. So you do need to notate that the health assessment is unrelated to the chronic disease management plan on the day, and you need to do the same with the chronic disease management items. You need to notate that it's unrelated to the health assessment. And then you will be able to claim all of those items in one visit. I would also recommend, just in terms of compliance, that you do notate in your notes what situation the patient is in that you feel that it is appropriate to do a health assessment and a GPMP during the same visit. Again, just making sure that you're compliant with the item descriptors. And so we're moving on to the DVA CVC program. So the aim of the program is to provide proactive care coordination, the opportunity to support our DVA patients, and for providers and participants to work as a team to improve the participants' healthcare in a general practice setting. So the patients that can be eligible for the program are DVA card holders and DVA white card holders who have a diagnosed mental health condition and have the condition accepted under their DVA white card. So a part of the program is that the GP and patient work together, and the practice nurse, to develop a care plan to meet the health needs of the patient, manage the patient's ongoing care, and promote overall health literacy and self-management through a person-centered approach. So there's a lot of compliance and a lot of information on the DVA website, and they've got something called a CVC toolbox. It includes an eligibility tool, general information and templates for your care plans, information about when and how to claim, and a claim calculator. I think most people, including myself, find this toolbox quite complex, and it seems to overcomplicate a really simple program. So as long as your patient is eligible under one of those two criterias, and you contact your patient either face-to-face or via phone or video every month within the billing quarter. So this billing that goes through to DVA is quarterly billing every 90 days. The items are UP01, UP02, 03 and 04. So that the UP01 is your initial item that you bill on the day that you enroll and consent the patient. Your 02, 03 and 04s are your every 90-day billing, depending on if it was your practice nurse or GP who's had contact with the patient within the month. So to make sure that you are compliant and you're contacting your patient each month, that can be either a practice visit or it can be a phone call from your practice nurse. And it's all about just keeping in touch with your patients, making sure that they've got everything that they need, they're on track with referrals or anything else that they may need in terms of their healthcare management, and just going that extra mile to connect dots for them and to support them. One tip to keep up to date with your patient contacts and billing is to use the reminder system in best practice. I haven't used Medical Director if they've got something similar, but what I do is I set up a reminder for UPO 1, 2, 3 and 4 for each patient, so I can just run a quick reminder list every month, run through who has been contacted or who hasn't. We make sure we contact those patients before the end of the month, and then we can put our billing through. Okay, and so just going on to a little bit of compliance and troubleshooting. Generally, with the MBS items, I find it's really easy for people to feel overwhelmed, especially with the descriptors and regulatory compliance needed to claim specific items. My advice would be to keep going back and keep reading your descriptor. That can give you confidence sometimes that you're doing everything you can to fulfill those regulatory needs, and to write it in your notes. We do a lot of work sometimes, and if we don't write it down, it's not recorded in the patient folder. I guess it didn't happen. So that's the most important thing. Another tip is to implement templates and shortcuts to prompt for specific patient information that needs to be collected to remain compliant. So for example, health assessments, GP management plans, your CVC program, you can set up shortcuts and templates so you're constantly prompted to collect the information you need along the way. You don't need to rely on your memory. And yes, just be confident that you're doing your best and you're addressing each point needed in specific MBS item descriptors. And when you are setting up new things in your practice or new systems, I always like to refer back to the original item descriptor when considering specific scenarios. Just to remind myself, if I've forgotten something, it's so easy to think that you're doing the right thing, and then you go back to the item and go, oh my God, I can't do that. And if you aren't sure, please get advice in writing through Ask MBS. It means that you'll have your response from them in writing, which you can always keep for later. If you do call the phones, there's often a lot of inconsistency with who's answering, and yeah, it's just not to be relied on really. And so if you're making a big call and you need that answer in writing, so use Ask MBS. It's an excellent email service, and you'll get a reliable answer. I think that's all I've got today. So thank you very much. Yeah, I think we have one.
We were gonna, yeah, so we've got one more speaker, and then we thought we might just have questions all at the end, if that's okay. Thank you, Sam. That was very informative. Yes, we'll do questions after, but I'll just ask Taylor Carriage, who is our Indigenous Health Program Officer, to come up and talk to you about MBS items for Aboriginal and Torres Strait Islander patients. Thank you, Taylor. Oh, you need one.
Oh, Jesus Christ, I'm already breaking stuff. Sorry. Let me make sure I'm pressing the right button. Yes. Jamaga Yurabini Nindiwan, Naga Taylor, Naga Maramarang. So good evening, everyone. My name is Taylor and I am a Maramarang woman. I will preface this by saying that this MBS side of things, my teammate Naomi, Dr. Naomi Luck, usually does the MBS item stuff. So I might not be able to answer your questions as well as she would, but if I can't answer them, please email the primary care team inbox and we'll make sure that she can get back to you on those. Okay. Shall we push ahead? Thank you, Kate, for the acknowledgement of country. So, Aboriginal and Torres Strait Islander People's Health Assessment. I pressed a button. The 715 MBS item that I'm sure, or I hope that you've all heard of. It is designed to address a number of contributing factors to the high burden of illness among Indigenous people in Australia. For non-VR doctors or non-vocationally registered, I hope I got that right, doctors, the item number is actually 228, just so that people are aware. Just to fill in a bit of the gaps, almost 2/3 or 63% of the total burden of disease among Indigenous Australians is due to chronic diseases, including mental health and substance use disorders, cardiovascular disease, cancer, and musculoskeletal conditions and injuries, including suicide. And almost half, 49%, of that burden could be prevented by empowering people to overcome these deficits, particularly by giving them the tools and knowledge to help reduce risk factors like smoking, alcohol, illicit drug use, obesity, and dietary factors. This is why the health assessment is such an important tool. It is an early intervention, early prevention tool. These slides, just so anyone, because I heard questions earlier, all the slides will be sent out afterwards. So I'm not going to read everything word for word. But unfortunately, the number of Aboriginal health assessments nationally is going down year over year. So our population continues to increase. So I'm really trying to encourage our practice nurses and our GPs to call your First Nations patients. Don't send letters and text messages, because generally speaking, I know for myself and a lot of people I know, we don't respond to those. But for the practice nurses that I've spoken to who do make those phone calls and book those assessments in, they get a much higher percentage response rate from First Nations people. It's also really important before and during and after any health assessment or appointment with a First Nations person to actually establish a relationship. I know it's time consuming and we're all time poor, but you cannot expect honesty from people who are afraid of professionals if you don't establish trust. So I'm just going to put that out there early. What are the benefits for the patients? Obviously, early detection of a patient's risk of illness helps ensure getting management in early before acuity happens and hospital presentations and all the complications that go along with that. And it is also focused on improving your patient-centered care, your preventative and early intervention-focused care for your First Nations patients. I'm going to go into all the numbers now, so this is the part I'm bad at. So the practice benefit obviously is $241.85 per patient, and also gives you access to a bunch of other MBS items after the fact for the patients, including, so you can have one every 9 months, any age. There are different ones for different age groups. A practice nurse or Aboriginal health worker or practitioner can help with most of the assessment, and then a GP has to sign off, I think, the final parts of it. It can be done, as it says, through video appointments, and all the information is available on the RACGP website as well. Also, health pathways. We have a lot of information about this and other Indigenous health pathways on health pathways, so make sure to check on there as well. We also have a toolkit available on the CHN website, which is for general practice staff at every level to improve your health and care of your First Nations patients. Alrighty, so then following up, the follow-up services, the completion of the assessment can enable patients to access Medicare rebates for up to 10 follow-up services per calendar year. These can be provided by a practice nurse or an Aboriginal or Torres Strait Islander health practitioner on behalf of the medical practitioner. More MBS item numbers. I'm not going to read them all out to you verbatim, but they'll be in the slides that are sent out. Further follow-up services, so the completion of the health assessment, you can access allied health services for your patients. So that's on top of if they have a chronic disease management care plan, you know, you get your 5 bulk bill, you get another 5 for doing a 715 assessment as well. More MBS item numbers I'm not going to read out. So this is kind of a bit of a flow chart on how to go about it and how to do the follow-ups and what to do. And then I'm going to get into the really exciting dollar signs. So this is an example of the revenue that a practice could be achieving if they were to do their health assessments for their First Nations patients on a regular basis. Obviously, we understand that general practices are a business as much as they are a place to care for people. So it's important to understand that there is actually good financial benefit to you as a business, as well as good benefit to your patients as consumers of healthcare. That's all the other items and things. GPMP, TCA, with follow-up in the practice, as I said, gives you more services and more, hopefully, more outcomes if done correctly. I think that's all. There's a bunch of additional resources that I'm listed here, as well as on our website and on Health Pathways. As you can see, Health Pathways. Kate already explained how to access Health Pathways, so I won't go over that again. But I think we go on to the questions now. So I'm gonna stop reading things off screen. Thank you.
While you're talking about the Aboriginal and Torres Strait Islander health toolkit, that QR code there will take you straight to it on our website, and there's lots of these sheets down the back if you're interested.
Cool. You need this back.
Right. Just leave it here. Oh, thank you, Sam. Thank you, Taylor. And we'll now open up to questions. Yes?
Take it on the other side.
How's that? That's good? Great. Yes, please.
Just wanted to ask Taylor about those item numbers, 732 and 721. Is that going to change in November as well for the Indigenous community?
I don't believe so, or if it is,
No.
they haven't told me.
Yeah,
So
I haven't seen anything about that yet.
yeah,
Yeah.
watch this space kind
Yeah.
of a situation.
We will share information as soon as we get it, but you may get it at the same time as us. Yeah. Yes, please, down the back.
Question. The first one is, we often get requests from nursing homes, and this tick this box to say that I, as a GP, have contributed to a management plan in the nursing home so a patient can have access to the dietary. Firstly, I have contributed to a plan, and it's also my understanding that nursing homes are supposed to provide those services anyway. And I don't obviously some. So Chris, does anyone have any comments on that?
That's out of our, beyond my knowledge. To assist with that, we do have an older person's manager who may know a little bit more. This is kind of moving into residential aged care homes is new for us, so we're learning as well.
Another question.
Yeah.
If a patient's in the MBS and they're already receiving funded services through the MBS, are they eligible for a GP management plan to get extra services? Yes.
Yeah. Being a part of the NDIS scheme doesn't mean that you don't get access to general health assessment and GPMP items.
That's cool. So if they're on an NDS, they can get GP management plan visits as well.
Yeah. I'm just remembering too, those 5 sessions, rebatable sessions aren't free. Yeah. So allied health practices, they'll cheer on about this, but they are paid appointments. So those 5 sessions are rebates. Yeah.